Hello, we're going to finish the urinary tract. If you listen to this before lab on Wednesday, I'm trying to get this all in so that we'll have everything done on Wednesday that we need to have accomplished. So I wanted to finish this now. Then on Wednesday, I'll give you the lowdown about what's going to be on, how we're going to work the final, and which will be the following Wednesday, of course. And then we're done with the class. And everybody's in good shape as far as I can see, so I don't think there's a lot of. Hopefully, make this a stress-free finish to the laboratory. And with further, and this is just the completion of the urinary tract that I'm doing right now. So here we go. Hopefully the phone won't interrupt me, but it might. Never can tell. I'm at home doing this, of course, and inevitably there are phone calls. So this is kind of where we left off. It's called the juxtaglomerular complex. I do not know if you are covering this or have covered this in lecture. It's probably getting around that time. My understanding is most of the folks have started. Basically, when we look at the anatomy, this is a critical area. It's much more functional than anatomical. So I'll give you the anatomical lowdown and we'll go from there. So here we are. So it has every nephron has one of these, and effectively, it's where the tubule system in contact, typically with the afferent arteriole, come into play, and they're very very close to one another, uh, as you'll see by the diagram. And they're much more physiological, and you should get this in lecture, I'm sure. Basically, they respond to changes in salt concentration, in pressure, and even sometimes osmolarity. So it's kind of interesting. I mean, that's a lot of the controls that are there. They have an area that are in that ascending limb, typically of the tubule, called the juxtaglomerular, which is part of this juxtaglomerular complex, rather, called the macula densa. And so this is an area where you have chemoreceptors for salt. Then you have granular cells in the arteriole itself. And what happens, these are smooth muscle cells that are there. And they have the enzyme renin that are there. Okay, and so they respond to their mechanical receptors respond to pressure change. And this is really how blood pressure is controlled by the kidney itself. Most of it's autoregulated. As long as the blood pressure is in a reasonable range, little highs, little lows, little variations in salt, whether you're thirsty, whether you just had a bag of chips or whatever, these are all things that will impact this, of course. And there's messenger cells between them, okay, with gap junctions that are passing signals. And that's really what you're going to see in the diagram. So here you can see the tubule as it comes up, whether it's the collecting duct, whether it's the ascending loop, whether it's the distal convoluted tubule, it's right around that same juncture point. These are the salt sensors. Here's the interconnecting cells, and here are the pressure pushes against these and releases the granules of renin. And renin is really potent. It elevates your blood pressure. So if there's variations in pressure, it's going to adjust it by either making more or making less or making no renin whatsoever. And what it will do is effectively it will alter the flow here. If you got to get rid of fluid to lower blood pressure, we let more in. We open this up, we close this. That way there's more blood circulating through. We create more filtrate. If you have more filtrate, you're going to make more urine and get rid of water. And and similar variations here. I'm not going to go into the physiology of it. As you can see, there's a lot of processing that goes on. We process, and I think I said this initially, I usually do, 40 to 45 gallons a day of filtrate is created. We 30 times a day, our bloodstream basically goes through our kidneys. Okay. And so the volume, I beg your pardon, 60 times a day. So what happens is that, and we use up a tremendous amount of oxygen with it. And effectively, what urine is 1% of this filtrate. What does that contain? Mostly it contains stuff. It contains uh, waste products, mostly nitrogen containing waste products. It contains a variety of electrolytes and chemicals and a certain amount of acidity because it's slightly acid and it's typically hypotonic. And you'll see the construction. Again, this is more physiology, but that's what it does. And these are the three steps, very famously: glomerular filtration, okay, tubular resorption, and tubular secretion. I always add in a fourth, which is the something that we don't touch on here, which is the countercurrent multiplier and exchanger system, which really concentrates the fluid. But that's an aside. That's just the way I do it. So what happens is you have filtration happening at the glomeruli, then a tremendous. We basically resorb the 2/3 of it by the time it gets into the loops, and then we finalize it. The proximal convoluted tubules are mostly reabsorption and some secretion, where the distal convoluted tubules are mostly secretion and some reabsorption. We even resorb stuff we're going to get rid of later to create gradients to facilitate it. And there's a lot of utilizing the energy in more ways than one. So you have secondary active transport mechanism. They go over all this type of stuff. And again, filtration is based on the pressure change, so we don't have to use up the oxygen until we start to move stuff back and forth across, bringing them back in or bringing them out of the convoluted tubules or other locations that are there. And the highlight is the fenestrated epithelium and fenestrated endothelium rather, have the tiny holes in it and the little podocytes that can control the openings. And this is the rendition that you can see here. And this is, they take this directly from a micrograph. So, this is just what the heck it looks like. So it's pretty darn interesting, I think, in that regard. And that's basically what you have to know. The rest of this is all physiology. That's there. And then they go into all the different kinds of controls. And again, this is more physiology. Very important. Wherever you're going, know the renin, angiotensin, aldosterone mechanism. That's going to be certainly part of physiology. That's certainly going to be part of things for you going forward. For many of you, particularly if you're going into nursing, you have to understand the impact of this that the kidneys have all over. And we're so conscious of at least I don't know what they call it today, but in the old days we called it I and O, input and output. We have people, you're really monitoring their fluids. You don't want them to have too many. You don't want them to have not enough. You have to monitor all of those things in the context of, how should I say it, of really what's going on. You really have to, what particularly with patients, are they dehydrated? Are they overhydrated? Are they tennis? Are they failure? And this is an important mechanism. They summarize it pretty nicely here in the different chemicals and all that stuff. All of this is if you're not putting out enough urine, then you're in danger of the kidneys failing, or whether the blood pressure has dropped. Oh, there's a lot of factors. Is there an infection, reactions to transfusions, injuries to it? All of these things play out. So I thought that would be the first little nugget. And there's not a great deal anatomically. And so this is a relatively short presentation in this next section, which is B. And in B, they talk a lot about the countercurrent multiplier and exchanger. That's the way we concentrate urine. It's very, very active at night. It starts literally before we're born. And as we're born, we develop this sort of interesting relationship within those long juxtamedullary nephrons, those long loops of Henle. And there's concentration variance in the soft tissue and what's called the interstitial tissue there with different degrees of osmolarity. So it's more concentrated to get to the bottom. And it utilizes the hairpin turn and the way it's flowing. And all of it facilitates constantly water being pulled out in the descending limb, which is thin and permeable to water, and solutes being pulled out to balance it out in the ascending limb. And then that's the multiplier. And then what happens, we constantly have to exchange with materials in the bloodstream so we can maintain effectively what causes this gradient to occur. So here you go. This is mostly physiology, resorption, and whether it goes through the cell or goes through little things and the various chemicals. And if you're going to do that in physiology, that's fine. And again, we use a lot of co-transport or antiport, meaning we use the energy, and we'll bring something else for the party coming along with the sodium, like glucose, or we'll move other stuff out at the same time. We'll go backwards and forwards with it. So you can see the gradient and the pumps create that push, and it's really a glucose, amino acids, ions, vitamins. So you're trying to maximize what you're doing for energy. And in the distal convoluted tubules, mostly water resorption plays a role, whether you're dehydrated or overhydrated, will depend on whether things like antidiuretic hormone or aldosterone are active. in those areas. And I'm sure that's something you'll focus on in physiology. Transport maximum means there's only so many receptors for, like, glucose is the perfect example. There's only so much sugar you can pull back at any one time because there's a limited number of places where the sugar can move through. If you overload those, if they're constantly full, over time they get damaged. And when they get damaged, it reduces your ability to move glucose. This is the tragedy of diabetics who are poorly controlled. They lose their transport maximum. And what happens is, let's say it's 180, for argument's sake, that you can, if your blood sugar is 180 milligrams, uh, you can transport that back. But if it goes to 200, those are saturated and you're going to start to lose it. But while it's saturated at 180, it's starting to damage those transporters. Then it goes down to 150 or 140. So that's why it's so imperative to keep diabetics under very, very close control. It's a point I make when I do the physiology in my advanced, or occasionally when I do AP2 lectures about that. So, I mean, just a little nugget there that you might find of interest. And the way all these different chemicals work is physiology, and that's really the sum and substance of, there's a multiplier and the exchanger, and hopefully you go through it. And like I said, this takes a long time to create, starting when we're born. Babies can't do it. How long does it take for a baby to get out of diapers? Okay, somewhere age 2, age 3, whatever. They're all different. There's a lot of variation. Some early, some later. And what happens is that's the ability to concentrate urine. So and also to control the sphincters and all of those types of things. So it takes a little bit of time for that gradient to be established. And they explain it pretty well in this. It's a very complicated area. Every time I explain it, I seem to understand it a little bit better. And I've been explaining it for 20 years, which means I don't understand it yet. So that's part of it. You can scroll through this as well as I can. So I don't want to do it. I already did it a couple of times this year. No more. So, and they utilize all of these things. A lot of times, we use diuretics. Used to be really important means to treat blood pressure. We're different now because they caused a fair amount of problems. People having to constantly go to the bathroom, it was hard to work. They lost a lot of potassium and a variety of things. And some things are problematic. Alcohol, why people, when they go out and have a few drinks, a lot of times you run in the bathroom. That's because it inhibits antidiuretic hormone. And so there's caffeine. They inhibit the reabsorption of sodium. And when sodium goes, water follows it. The loop diuretics are classically used in the hospital because they're very efficient, and you can monitor electrolyte levels to make sure somebody isn't a problem. And the idea of an osmotic diuretic is the fact that if you're spilling sugar, like in a diabetic, water is going to follow that to balance that out, to make sure that the urine is still passable. So it's going to pull the water with it. That's an osmotic diuretic. It's the force of the solute dragging along the water. And sometimes we use this by intent if we want people to expel things. You do different things, try to pull stuff in. When people would ingest a poison or a toxin, either intentionally or accidentally, we'd use things like activated charcoal to neutralize it, and then other stuff to pull it along. So that's why the urinalysis is a very good kind of snapshot. Plus, we get rid of a lot of drug agents and also obviously illegal or controlled substances that can be monitored with this. Uh, Sometimes there's false positives, but the reality is that, like when you go for a job and you're doing a drug test, and I don't know what the rules are. My middle one, who's commercial driver's license, CDLA with hazmat endorsement, means, I mean, anytime anything happens, he had a lady rear end him, pop right in his backside. He had nothing to do with it. Go take a drug test. When I'm dictating this on Easter Sunday tomorrow, he is supposed to go to get his job physical because this is about the time of year that all the construction work starts. And what are they doing? As well as doing the physical, urine testing. And they'll typically take 2 samples. They'll take 1 sample and divide it into 2, a basic sample, they dipstick. And then if that turns positive, and you have a second sample, you can send for more comprehensive analysis, see what's called a false positive. In the cases, these days, he tells me it takes a week to 10 days for that sample to be processed. I think they just take it directly because it has to go through TSA. Transportation Safety is who endorses those licenses. That's where he gets vetted by that. So it's an interesting process. And needless to say, he never puts something in. He never, if he wants to go out and have a couple of drinks. It's always when he's on vacation or he knows he doesn't have to go into work for a couple of days to make sure that's out of your system because you don't want to have a problem. And we measure. We use substances that are neither absorbed nor secreted to monitor how effective the clearance is. And it's something they may talk about. But the last anatomical bit and all the composition and what's normally there, I'll leave for that and all the things is this. This is basically the tract, not the kidneys. We call this the urinary tract. Most of the problems are here. UTIs, urinary tract infections, are as common as any infection, and certainly the most common nosocomial or hospital acquired infections that we see anywhere. So that's the first thing to talk about. Effectively, once the urine comes out of the tips of the pyramids, it drains into those series of calyces, first minor, then major, and eventually they are collected by yet another giant calyx called the renal pelvis. And the stem of that funnel is, you guessed it, is the ureters. So now there's no processing that goes on. There's only problems. And the problems are, as you'll see anatomically, is that the ureters, just like anything else, they can expand or they can contract. The hallmark epithelia for the ureters, for the bladder, and for the start of the urethra, okay, is what's called transitional epithelia. Transitional means, and you might remember this from AP1, it's got usually about 12 layers. It appears when the bladder or the ureters are full that they have, how shall I say it? They have maybe 2 or 3 layers. It's squished down. And when it's empty, you can see, and what distinguishes it from stratified squamous is sort of rounded on top. So they're very forgiving. It's almost like they're elastic. They get replaced all the time, mind you. But if you look at them, the stratified squamous, the outermost layer, the apical layer, is flat. This one is rounded. That's what distinguishes, even though you might have multiple layers. Again, so typically 7 to 12, that type of area, depends on where it is. The tubes are relatively slender in the ureters. And what happened, they're retroperitoneal, so they're not moving anywhere. And what happens is effectively it's almost like a valve effect. When the bladder fills, it doesn't back up. Okay, and this is also helpful vis-a-vis infection and things like that are there. The lining is the transitional smooth muscle that's there, and it's somewhat peristaltic in nature. Sympathetic and parasympathetic intervention. Sympathetic slows it down. That's fight or flight. Parasympathetic is usually what's acting. Adventitious, the outer layer, which means it's not moist. It's not designed to move. And this is what the interesting part. So you can see these little kind of nooks and crannies is the way I would describe them. Little areas where stuff can get trapped. And the big problem with stuff getting trapped in those areas is if it is got a core of blood, which is not uncommon, or calcium, or infection, or uric acid crystals, they can be quite irritating and cause spasm. That's what we call urethral, URETRAL, colic or spasm, and that's what a kidney stone is. It's not really in your kidney, it's mostly in the ureters. It can be in the bladder, it can even jam up things going on the way out, so to speak. So you can see this is the typical layer. Let's see, we have the transitional epithelia, you have the underlayer, you have the smooth muscle, and you have the adventitia that are there. And so renal calculi, also known as kidney stones, mostly found in the ureter, but it can be elsewhere. Extraordinarily painful from the spasm, and the problem is the blockage will back things up and potentially cause damage, at the very least, problems with the kidney. And so you can see lithiasis means there's a stone, just like we did with gallbladder stones. You basically use the typical mechanism is called lithotripsy. We're using high frequency sound waves. Someone's in a big, like a bathtub of water, and sedated, and they're using sound waves to get them to sort of those sound or acoustic waves crumble the stones so they can pass more easily. And there's lots of different factors, much more common these days in women. Probably has to do a fair amount with calcium and certain types of supplements. You have to get the right kind of calcium, generally calcium carbonate. We used to call that Oscal for oyster shell calcium. But whoever takes care of you or whatever resources you use for your health, men and women alike, make sure you're taking the right calcium. Hydration, hydration, hydration. Don't be like me. I tend to not drink a great deal. It's just the way it is, and I should do more. Okay, and so the bladder itself is just a storage sac, and this is the problem. Why I'm so familiar with this, where my cancer is, or was, at least for the time being, as far as we know. Retroperitoneal on the floor of the pelvis. The prostate is sort of underneath it, where what they call it the neck of the bladder, where it opens up into the urethra. So that's a problem zone. And females, it's a little bit more forward facing, between, as you can see, it's anterior to the vagina and the uterus. So where it is anatomically, and it's something we'll review a little bit in either a subsequent dictation or I'll do so in class, depending on time. So where the ureters come in and the urethra come out in both men and women, it's flat because usually the bladder has those ridges. When it's filled, they flatten out. When it's empty, they form rugae, just like the stomach. Ridges that are there, but the trigone is flat, and that's the problem. Is there's not a lot of motion, and that's where infections tend to be. The muscle is very famous, it's called the detrusor. That's there. 3 layers of smooth muscle, as you can see, longitudinal and circular. That's there, and it's a real useful barrier. It's what I appreciate because big muscles create barriers for things like infection spreading and also for cancer spreading. So mine was confined, and I'll back up a second. If the bladder looks a little bit, then we'll get to a picture of bladder. I'll go forward here. So even though this is female, what happened is in that lining, it's a question of how it's called. It's mine was in the transitional epithelia. It's based on how deep it goes. If it goes into the muscle, it's big trouble. I was fortunate that it stayed really in the lining cells and maybe just in contact with the underlayer before it got to muscle. So I didn't require anything major, just a lot of treatment and wasn't necessarily pleasant. So the muscle plays a big role that's there. And so the distinction in the male is more complex because we have a shared system for sperm and for reproductive physiology and urinary physiology share the system. That's a problem. Okay. And that kind of problem is difficult. Okay, so there's a lot of areas where it can go wrong. It can go wrong, as you'll see when you get to reproductive, where the two systems meet. Okay, and that can be a problematic area for sure. It can be a problem here prostatically. Most men, and we'll go over this again when we look at the male reproductive physiology, which is what's up next. Once you get men start to have problems with this about middle age, 40s to 50s, and almost everybody 60s and 70s like I am have some degree of prostatic disease. Usually it's not necessarily cancer. It's typically more just thick, harder, uh, more difficult, harder to empty the bladder, things like that. There's a lot of prostatic procedures, and I've had them. So this becomes a problem area in the prostate. So you have an area where you have the urethra, the long tube that exits. It's basically transitional as it starts to go through here. Then as it goes from sort of inside to outside. So you have 3 areas: the prostatic urethra, surrounded by the prostate, where it picks up prostatic fluid in the process of undergoing where during ejaculation. Then you have the membranous urethra, which is sort of like I call inside to outside. As it passes through both the sphincter and this diaphragm, this opening, it basically makes the transition to the exterior. Now you're making transition to mostly stratified squamous because now it's more protective in nature. And so you have the very long, comparatively spongy urethra. So this is in the male long, and we'll go over the numbers. And on either side, you have erectile tissue, and surrounding it, you have 3 different types of erectile tissue, and we'll get into that aspect and all the relevant anatomy because that's more male repro than anatomy than necessarily urinary tract anatomy. And the female, different because once it exits, we immediately go from transitional to stratified squamous. The problem is the proximity anally and vaginally, so it's much more prone to it. The short urethra makes it easy for infection to get into the bladder. In the male, the long urethra makes it usually more painful over time. And as you can see, when it collapses, you have those ridges or rugae, and typically it holds a pint, can hold more if necessary. Uh, if you're a nursing, you're going to do a lot of urograms, which is an ultrasound they do now to make sure patients empty their bladder. Because there'd be a concern if they don't that you could end up with urinary tract problems, and that's called an IVP. You give someone intravenously a dye and you image it so you can look at the calyces, see if there's any blockages, etc. And so again, we start with pseudostratified columnar, transitional near the bladder, for stratified squamous as we get to the exit. And that's the way it goes, a series of sphincters that are there, the three parts that I told you about. And again, this is part of the problem. There a vast majority we have non-sexually and non-sexually transmitted infections. Non-sexually, there's an abundance of yeast infections for a variety of reasons. I get to in micro, and for sexually transmitted, there's another abundance of regions that are there, and all of these are inflammations thereof, and the physiology is voiding. And that's about it. Alrighty, that finishes our urinary tract segment and our renal or urinary physiology, and we'll address the reprophysiology, male and hopefully female. We'll try to get it all in on Wednesday. Thank you very much. See you then. Bye bye.